We are now live. Great. Hello, hello, IC healers. It's Dr. LaGreca here, and I'm here with a special guest, Dr. Lenhardt. I'm going to tell you real quick about how I even stumbled upon Dr. Lenhardt. I was doing some research for a client on oxalates because it seems like oxalates are very confusing to people, and the connection to oxalates and IC is not something that's been brought upon by the medical community at this point in time. So as I was Googling, I ran upon a really good blog and I was like, oh, let me read this. And it was nice, short to the point. And I looked up his bio and I was like, I think I want to meet him and hear his story. And so we met and he told me his story. And I was like, I think he'd be a really good candidate to come in and talk to my community about some of these health issues that we're seeing that are related to diets. So I brought him on, and here's Dr. Lenhardt. Hi, how are you?
Hey, how are you? Nice to see you.
Nice to see you too. So we're going to start this conversation because this is really a conversation. This is not, we're not preaching to you today. We're not here to talk to you about what you should and shouldn't be doing from a medical standpoint. This is about, we're going to have a conversation between us about what we feel in our own story and how it's affected us, and then lead that into what we are finding in our own clinical practice. But before I begin, I want to make a broad disclaimer. This is not meant to be medical advice. If you have a health condition that you need a diagnosis for, please go seek your health practitioner or medical doctor for diagnosis and treatments. So we're just here to have a conversation, not necessarily to give you treatment suggestions. Okay, so let's begin with you. Tell us more about how you got in your medical doctor and how you started to see things in a more integrative way in your practice, including your own personal story that you had that led you into this journey.
So I started working in a small town north of Boston about 20 years ago in Hamilton, Mass. I grew up in Massachusetts, more or less, and it was a small town I never even heard of until I interviewed there. And pretty soon after I was working in this town, people were coming in to see me, worried about that they had Lyme disease and worried about chronic Lyme disease. And I realized very quickly that my understanding about tick-borne disease was incredibly limited, and most of what I had been told and taught in my training and from colleagues was either incomplete or wrong or, very far from reality. So, most people going back with question of chronic Lyme disease are discounted by the mainstream medical world. But everyone came in, they were regular people, reasonable people that said, I have joint pain, muscle pain, headaches, fatigue, sweats, and all these symptoms. And I was told by 5 medical specialists that I couldn't have Lyme disease because my tests were negative. So it really started for me with Lyme disease, where people were coming in, they had legitimate symptoms, they weren't hypochondriacs, and I wanted to help them. And so I started doing a lot of intensive research into tick-borne disease. And I would say in the last 18 plus years, that's one of the specialties of my practice. But so things basically took off from there because tick-borne disease is incredibly complicated. And one of my lines going back from the beginning is that the mainstream tends to underdiagnose and undermanage, and a lot of the Lyme practitioners tend to overmanage. The old school way of managing Lyme disease was to put people on 3 to 5 rotating antibiotics with supplements for indefinite periods of time. And I think we can look back, and I look at the way I've managed now and the way people are starting to manage. And even the most well-intentioned Lyme practitioners, I think, we're managing a complex issue in a way that was too simplistic. So that was the first issue that really brought me out of my comfort zone. And from that point until now, my goal is to understand things as deeply as possible and as in a sophisticated way so I can help people. And it's really no more complicated than that. And I'm willing to, assuming safety, I'm willing to do just about anything and learn from just about anyone I can, so I can improve the care I deliver for what has become a fairly sizable group of complex patients in the practice.
So you had your own experience with patients who were coming in and they had tick-borne illness, and you were realizing that you were limited in your tools, and so you decided to seek elsewhere and broaden your horizon, and stumbled upon this whole entire world of functional medicine, which it's massive.
Yeah, I would say that. So that's the one primary thing that drove me forward, and the other one was much more personal for me, which was my son, who's almost 14 years old, from a very, very young age. I mean, you look back, and he was from as long back as I can remember, had significant behavioral issues and explosive issues. Um, my wife and I saw anybody and everybody, neurology, psychiatry, psychologists, counselors, therapists. Um, I would say somewhere between 15 and 20 different people to try to understand what was going on with our son, why this warm, intelligent, child would have a hair trigger and would become combative and explosive and destroy a room. And it was really a Jekyll and Hyde scenario. And what became clear after seeing so many practitioners was that the goal of the providers was to make a diagnosis with almost no understanding of what was going on with him. And I didn't really care if he met criteria in the DSM for oppositional defiant disorder, intermittent explosive disorder, ADD, bipolar. We were told he was on the autism spectrum. I mean, everybody gave us a different diagnosis or diagnoses, and not a single person was trained. They were all nice people. They were all well-meaning people, well-educated, and nobody was trained to understand what was going on. So over several years, my wife and I had to figure it out ourselves, which is really not the way it's supposed to be. I mean, the father is not supposed to take care of their son, but in these situations, you do whatever you had to do. So we found that he had copper overload and food sensitivities and sensory integration dysfunction, and he had all kinds of things. We had to change our parenting style. One of the most insidious problems with kids with behavioral issues is that the parents basically get judged and lectured based on this standard parenting model where the parents are the boss and the parents are the dictators, and they just need to enforce their will on the child. And that is, for a son like mine, that is the worst approach possible. And grandparents and everybody was, giving us all this bad advice. So ultimately, we figured it out, and ultimately started to improve, and he's, been steadily improving for the last 10 years. And now, he wouldn't meet criteria for any diagnosis. Whereas I'm sure when he was 5 years old, when he was asked to leave his seventh school, um,
Wow.
I think he would have met criteria for 5 or 6 diagnoses. We got to the point with the schools where he was asked to leave 6 or 7 schools, sometimes after one day.
Wow.
We ran out of schools, and we were left with either homeschooling him or moving to Florida, because Florida has a better, because he was a gifted child. So Massachusetts, to our surprise, ranks 50th in terms of how they manage gifted children, and they have very poor special needs. At least back then, I think it's improved tremendously, actually. But we were going to move, or we were going to homeschool. Ultimately, he had to go back to a Montessori school where he was the only older child in the school, but they saved us a bit. But so so the Lyme disease nudged me out of the comfort zone, and having to figure out my son shoved me into the world of functional medicine before I even knew what that term was. I never forget a patient I saw 11 or 12 years ago, and I was talking about his hypertension or diabetes in a very functional way. And he said, "Oh, how long have you been practicing functional medicine?" And I said, "What's functional medicine?" So that night I went home and I looked it up online. It was probably a Mark Hyman source. And I said, "This is absolutely the way I want to practice medicine from here on." And, it's been an incredible path since then. I've learned so much, and I continue to learn. And oxalates is, in some ways, I would say the most recent, most important issue now in my practice. And like everything else now, now I have to be careful because I see it everywhere.
Yeah, we blame everything on it now.
So I
Yeah.
have to be careful not to go too far with oxalates, but
Yeah, there's definitely a tipping point with that. I completely agree with you. There's a tipping point, but it's like the new guy in town, and so it's like you start to actually have a cognitive, you're focused on that. It becomes like, oh, everything's bad. Functional medicine. So a lot of people listening right now are new to this, and some people are not new, but I think it's a great opportunity to give you that definition for both people, because what is it and how does it work? So I'm going to go ahead and read what I know, what functional medicine is. It is really designed to determine your root cause. You guys hear me say this all the time because I have a root cause investigation program. I mean, that's what I'm doing, and why is because if you don't find your root cause, you're not going to be able to find your healing path. It's like a mechanic who you go take him to your car to the mechanic and you're like, fix my car. And he's like, well, first I have to find out what's wrong with it. Nope, just fix it. That's not going to work. It's the same thing. So in functional medicine, really the underlying theme is to find your root cause. And from that, you are able to see where things went wrong. And that is integrating the relationship between your detoxification systems, your digestive, hormone, and immune system. And I want to add another element to that wasn't in my definition, but your mind, your soul, mind and soul. That's a whole nother area that's starting to get some attention. So that should be added to that because the mind is going to impact everything else in the body. So, and it really involves your lifestyle, which includes nutrition, exercise, which I talk about a lot, but a lot of people that I see don't like to hear that word because they're in pain and the thought of exercise is painful, but without doing it, you're not going to get better. So that's part of it. And then of course, your environment. So nutrition, diet, exercise, and environment, and finally your mindset. So, and it's really what it is people don't often realize that until these pieces come together, they're not going to get the relief that they want. And that's what the conventional model is missing. It's very good at, and this is just my own experience, and I think that's an area that needs to be improved. I think that the conventional model, not just in medicine, but even in any conventional model, even nutrition, like some of the nutritionists that operate conventionally, it's thinking about how to improve your symptoms, or we're thinking about how can we get to the root cause so we can improve your function of the body so everything kind of falls in line. So that's functional medicine in a summary. So now that we've kind of cleared the air on that, talk to us about how you first stumbled upon the big O word, the oxalates.
So I'll back up a step. I think when you and I talked before, I mentioned how interstitial cystitis came into my world, and it's classic where 4 years of medical school, never heard the term to my recollection, 3 years of residency, never heard the term.
Really?
Yeah, I don't think so. I mean, I either heard the term or maybe it was, if I ever heard the term in my 7 years of medical training, it was really as some rare entity that you would never see or something, and nobody ever diagnosed that I was around.
Wow.
Yeah, and so it actually, what happened was, even when I was in residencies, I'm sure that your listeners are well aware of this scenario where a woman comes in with classic symptoms of the provider thinks it's a UTI, and then they have some abnormalities in urinalysis, some microscopic blood, some white cells, some markers of inflammation. The provider says, oh, the easiest case I'll see all day, it's urinary tract infection. They put them on Cipro or Bactrim or something. And then, maybe they get better and maybe they don't. And all it takes is the urine culture. All you have to do is look at the urine culture. If the urine culture comes back negative, especially if this is a recurring pattern, it's almost always interstitial cystitis. I've worked at 4 practices now, and every one of the 4 practices, I've weeded out and diagnosed most of the interstitial cystitis cases just by going back to the medical record and seeing that you see urinalysis and they're almost always abnormal. And you see out of, let's say, 10 cultures, 3 of them are positive and 7 of them are negative. So I think a common misconception with interstitial cystitis is they sometimes will have a positive culture and will have a urinary infection, but that doesn't mean the person doesn't have interstitial cystitis, because if there's breaks in the bladder wall, the woman, typically female patient, is almost always more vulnerable to UTI. So you can see these things coexisting. It's not usually one or the other. But so back in residency, I diagnosed a couple of people, um, and I became very interested even back then in important conditions that were underdiagnosed. And I started working with medical students from Tufts Medical School maybe 12 years ago, and I used to rattle off top 10 underdiagnosed important conditions, and sleep apnea was always on the list, and interstitial cystitis was always on the list, and ocular rosacea was always on the list. And I mean, some of that's probably ego driven, because every doctor wants to come up with some exotic diagnosis that nobody ever figured out, and like, you're so proud of yourself for coming up with something.
Did you ever watch that show, Mystery Diagnosis?
I haven't seen that show.
Okay, that's a long time. It's an older show, but yeah, it reminds me of that.
But the classic thing is, like, the New York Times, Mr. Diagnosis, and all the shows and TV, their goal is still to make a diagnosis and to put a label on something. And you and I would never be satisfied with putting a label on something without an understanding, unless that label, like with interstitial cystitis, at least we understand what that means. At least we understand most of the elements of it in terms of oxalates and inflammation and, mass,
yeah,
and those types of elements. So at least it means something. But the most mystery diagnosis things that providers do in the New York Times is like, oh, we diagnosed lupus. Well, why did the person develop lupus? That is not, this is one of the classic differences between naturopathic, integrative, functional practitioners and traditional practitioners, where to most practitioners, making a diagnosis is the final piece of the puzzle, and then you're done, and then you treat it. Versus, like, why did that, okay, let's say they do have lupus. Well, why them? Why now? What happened? What set the stage? What genetic, epigenetic, nutritional, leaky gut, inflammatory factors set the stage for whatever the diagnosis is? So interstitial cystitis, when I was in residency, became an interest of mine because most people were undiagnosed. And I didn't know anything about oxalates back then. Like 99% of practitioners, and if you surveyed most practitioners nowadays and you said, what do you think of oxalates? They would say most kidney stones are oxalate driven, and that would be the end of it. And so,
because unfortunately, that's where a lot of literature takes them to when they do the research.
Of course. And so in what I call my re-education over the past 10 to 12 years, there are so many examples of a topic where I can go by how I was trained and the very limited understanding of that piece. Whereas, like, Epstein-Barr virus is much more important than mono, and oxalates are much more important than kidney stones, and on and on and on and on. So then the first article I wrote for a newspaper, the Salem News, like 16 years ago, was about interstitial cystitis. So it stayed with me in practice. And that was my inclination. And so I just kept learning and learning and learning. And then the last thing I'll say about oxalates at this point of our talk is, so what happened with oxalates is, and this has happened to me also many, many times, I heard about oxalates as being an important issue. And then I said, yeah, that's okay, that's fine. And I wasn't ready to hear it. I wasn't ready to receive it. And then 3 months later, it would come up, when some person I had respect for, or some article or some book, it would talk about oxalates. So I heard about it so many times. It was like a tap on the shoulder: oxalates, oxalates, oxalates. And I had to hear it, 4 or 5 or 6 times, or 10 times, or 20 times, until finally, at some point last year, I said, I think that this is a very important issue, and I really need to go right in and really try to take a deep dive and sort this out. And it's one of the most important issues I've come across. And the beauty of it is that of all of the most important things I've learned, it pulls a lot of them together, right? So if we talk about dysbiosis, if we talk about leaky gut, if we talk about nutrition, if we talk about mineral deficiencies, if we talk about fungal overgrowth, if we talk about that part of it, if we talk about mitochondrial dysfunction, oxalates are relevant to all of those things. So it, more than many other things I've come across, it really pulls it together in a unified way. And it's been really incredible. So now that I see people from that different perspective, it's giving me avenues to help people to improve so many different issues that I wouldn't otherwise, have the tools to do it.
Yeah, even people who don't scream that they have an oxalate issue on paper. And it's funny you say that because the same exact thing happened to me. I stumbled upon oxalates 10 years ago, 10. And I have IC, I'm in remission. And I remember when I first stumbled upon it, I went into the triangle oxalate group. And at that time, I was like, no and no. It was way too overwhelming for me. And the first thing, the second thing, it was like, you are telling me that I can't eat these vegetables are bad for me. You're actually telling me they're bad for me. No, this is not correct. And now I do blame the obesity epidemic for this because I feel like we are eating more higher oxalate foods because they're lower in calories because we have a lot of overweight people. And as a result, we're promoting this more to help with the weight loss. And I think that a lot of the food industry then went towards that because it became trendy. And so the paleo diet came and everything was oxalates, all the high oxalate foods within the paleo diet, and paleo diet was promoted for weight loss. And so I even though, you wouldn't think weight loss, I see, because a lot of people with IC are very underweight. I believe the weight loss, the obesity epidemic could be why we're eating so many oxalates. Because I've had a lot of my clients ask me, well, how am I going to explain this to my husband that you're telling me that these smoothies are bad for me? Like when I'm reading a magazine that tells me that they're good for me, and I explain, understand it's dose dependent. We were never designed to eat the amount of oxalates that we're eating, even evolutionarily, because ox factor, the bacteria in our gut that breaks down oxalates, doesn't thrive in a high oxalate environment. It thrives in a more medium low oxalate environment. So that tells me that evolution wise, we weren't even supposed to eat this many. So the human body wasn't even designed. And now we have dysbiosis, like you said, and now we have this trend of paleo. And so we're eating too much and we're also under metabolizing it and breaking it down. So now we've got this problem. So and then I did the same thing. I went away, I came back 10 years later, and I said, I'm going to relook at this again because I think there's something to this. At that point, I was getting my doctorate and I was able to understand the science. And that's when I was like, oh my goodness, what was I doing the last 10 years? Here I was juicing. I was doing celery juice. I was doing all this, and my UTIs were getting worse and worse and worse, and it was bleeding. And I didn't understand why. And now I look back, it was because of the crystals were passing through my urinary tract and it was damaging it and causing the blood. So, and I was actually told at one time, Dr. Lenhardt, that I had bladder cancer, even though I never got tested for bladder cancer. It was just one of those diagnoses that doctors like to throw around, which was very damaging to my relationship with my doctor, because I said, how do you know I have cancer? He says, well, anytime there's hematuria, there's going to be cancer, so you should get tested. I'm like, that is the worst explanation I've ever heard in my life. I said, I'm leaving. And I realized looking back that it wasn't cancer this whole time. The blood was actually coming from the oxalates, because once I went, oxalate, it all stopped. So yeah, so that's really interesting. So we have very similar, but that's good that we're both coming back and starting to put our eyes on this. So now, so to the listeners or the viewers who are watching, what can you tell us about with your history with IC? What is the conventional treatment that you've seen offered most of the time? And why are they not very effective? Like the medications, Almiron, amitriptyline, things like that. Oh, are you there? Can you hear me? Oh, yeah. Sorry.
I thought you were asking the patient. Sorry about that.
No, I was asking you, like, can you explain? Because some of the people who are listening are probably like, well, I know, I hear what you're saying, but I'm taking this amitriptyline right now, I'm taking this Almiron right now, and it's really helping me right now. So can you explain to us listening, like, why that long-term might not be a good strategy?
Yeah, there's a small interesting piece of that. So when I was in residency and I took an interest in interstitial cystitis, you know, the treatment at that time was Elmeron, which, you know, I think it roughly has a 30% success rate. If placebo is 25% for most things, then Elmeron is just barely squeaking above placebo anyway. But
Oh,
I,
wow.
yeah, I remember I was opened up a New England Journal of Medicine article, and they have little abstracts from other journals in the front. I haven't read that in probably 15 years, but at least I used to. And there was this article about interstitial cystitis from a Vienna journal where they used piroxicam and amateur tricyclic in combination, and they said that there was about an 80% success rate. So I was excited. Had diagnosed different people with interstitial cystitis, started using it, and people responded really well. And for years, and actually my article for the Salem News was based in part on saying there is this really effective treatment, which is piroxicam, which is a non-steroidal anti-inflammatory, basically like a super ibuprofen, and another tricyclic like amitriptyline, which is an old class of antidepressants that's now used for chronic pain and chronic headaches and some other issues. And it did tend to work well. And in my previous less enlightened state, I was pretty content with that. The problem, as you've alluded to, is tricyclics tend to have a wide variety of side effects: dry mouth, dizziness, urinary retention, constipation. Most people get dry mouth. And then the doses that they were using in the study for piroxicam, the strong anti-inflammatory, were double or quadruple what would normally be used. I remember I'd get calls from the pharmacist saying, do you really want to use piroxicam 20 milligrams twice a day, which is a mega dose? And so that was a strategy that works provide a lot of symptomatic relief. And then I would try to use it sparingly, only during flares. I would say, just when you get a flare, just hit it hard. And then it wasn't much on the prevention side. But during that stretch of time when I was managing the symptoms better, I really had no understanding of what was going on and what was triggering it. And so now, you know, my plan is I have every practitioner has different spiels. You know, we got the viral illness, don't use antibiotic spiel, and there's so many things that come up recurrently. And so now now my oxalate spiel is really rounding into form because I'm talking about it to so many people, and it is important to try to get it down in a simple way because it's a very complex subject and it's very overwhelming to people. And I do tell them that people are going to have to end up being oxalate experts on their own so that we can really have a dialogue, and they can ask all the right questions, and we can have a collaborative approach to this. So they will have to do some research. And the old passive paternalistic model of medicine, you know, it's slowly fading away, but you know, it's something like any of these chronic complex syndromes, it's even more important to have the informed, educated patient with the open-minded, reasonable provider that encourages a collaborative relationship. So now with people, I mean, you could ask me what my approach is for Lyme disease or fibromyalgia or interstitial cystitis, and I couldn't give you an answer because everything is so individualized. You know, I just saw a woman yesterday who I assumed had mold toxin illness, which is chronic inflammatory response syndrome. She's out of work, she's in pain, she's tired, she's foggy, she's miserable. She lives in a moldy environment, but she can't move because she can't work. She has her business, but so she's like in this terrible situation where she's stuck in this moldy environment. And then I did some research on oxalates as a cause for neuropathy.
Mm-hmm.
Where oxalates and crystals build up in the nerves, and it's been seen on the microscope in this study. And they use plasma oxalate levels. So actually, I'm curious as to your experience, if any, with that, because this is just as of 3 weeks ago in that study, they used plasma oxalate levels.
Wow, I've not heard that there's a test for that. Normally we do urinary.
So this is what's happened when I do exotic labs that nobody's doing. I have to memorize the lab code.
Yeah, I'd love to know.
So the lab code, like what we use for outside labs is ARUP, ARUP, ARUP Labs in Utah.
ARUP. Yep.
Yeah, and the plasma oxalate code, I have it written down. So
Sure. Yeah, go ahead.
2011697. So when I order it under miscellaneous in the Epic system, I put plasma oxalate level, ARUP code 2011697.
2011697, right? 2011697. Okay, plasma oxalate.
Basically, I've ordered that
Oh,
probably 10 or 12 people, and several of them have been high, and others who have definitive have oxalate levels have been normal. So what I would say about plasma oxalate levels, like other tests, it's the type of test that if it's normal, it doesn't help much because the person could very well have an oxalate problem, and maybe you're not
not
catching
excreting it. Yeah, you're not excreting at that moment. Yeah.
catching them in a high
Yeah.
oxalate state.
Yeah.
But if it is high, then that is a strong nudge that they have an oxalate problem. So this woman's oxalate levels are the highest I've seen so far with a relatively small sample size. She has no oxalates in her diet.
No oxalates in her diet. What are her, what are comorbidities that she has, like health conditions?
Um, I don't think she has any. I don't think I mean, she's a young woman. She's her early 40s, had her own hairdressing business. Yeah, I'd be hard pressed. I mean, she's got fibromyalgia and chronic pain and chronic fatigue.
That's it right there.
Wow.
Fibromyalgia and oxalates are like huge.
Exactly.
There you go. That's what it is.
So,
yeah.
So I mean, when you say comorbidities,
other conditions, and I mean, what is her main condition? Yeah.
Yeah. So she has most of the pseudo diagnoses in mainstream medicine: fibromyalgia, chronic fatigue syndrome, interstitial cystitis. Now, I don't really use those terms too often because they don't mean anything to me, but they mean more to me now because now I understand what they represent. But as I said before,
no bladder issues for her though yet.
She does have some bladder issues, but pain is the predominant issue. So actually, I was curious as to if you had any experience with plasma oxalate levels.
No. So what I used to do is the organic acid. I still do the organic acid, but I primarily used to only focus on that. And then I started seeing a pattern where I know this person has an oxalate issue. I see it. They're eating it. They have all the symptoms, but we just didn't catch it that day. So I added on now the 24-hour urinary quantitative test, because I feel like, and we may not catch it that day either, but it's a higher likelihood that we will see that threshold higher on the 24-hour collection, because I believe that we do have a pattern of our excretion throughout the day. I've seen charts. I don't remember how it was, but I know there is a pattern on how oxalates are excreted throughout the day. So I figured with the 24-hour, we're more likely to catch it, and then we can kind of compare the values. But now you can add this on top of it. Now you've got 3, because that's a key thing. You have people have to buy into the idea, and they want the labs to buy into it. And I needed to do that for this client because this person was not going to buy into it because they did not want to change their diet. They were very comfortable with their smoothies. And so I had to prove to them that this is a problem. So.
Right. Yeah. So I've used 24-hour urine oxalate studies, organic acid tests like you. I consider the sort of gold standard if there is such a thing, especially because it's giving us fungal markers and markers of B6 deficiency and other things that are incredibly valuable. So if somebody had one test to do, of course, you and I would both probably say do the organic acid test. But, I don't know about you, but I run into a lot of people that $200 or $300 makes a difference. So I'm always looking to try to keep expenses down for people. So if I do 24-hour urine oxalate study, most of the time it's normal, even if I think they do have an oxalate problem. If I do serum oxalate, most of the time it's normal, but at least it's something I can do. And you're right. If people want to tell their friends and family, like, oh, you saw Dr. Lenhardt, what does he think's going on? And they say oxalate issue. Of course, nobody knows what that means. And then they say, well, if they can say, like you said, here's my elevated oxalate level, then it does take on
they buy into it. It's just unfortunate though. That's just kind of the nature of what we're doing, because it is invisible. It's invisible. I mean, it's there on a microscopic level, but unless you're actually going into the tissue and actually analyzing under the microscope, you're not going to see it. Now, I have seen some very interesting images of, the oxalates even surrounding our own microbiome, certain bacteria and you see the little oxalate crystals that are actually adhering to the bacteria, which explains the connection with some of these infections. And I've always told people, like, I've seen a very, very interesting trend with Enterococcus faecalis, that one, and oxalates. And now I know it's an oxalate degrading strain of bacteria. So when you see those images, and then I also saw a really interesting image of aspergillus and how it has the oxalates growing. So that the patient you were just talking about, was that the mold patient?
Yeah. So it's becoming clear to me that people, and I've said this for a while. I said, you can have mold allergy, you can have mold toxin illness, or you can have mold overgrowth or fungal infections, or all of the above. Now we throw the oxalates in there if you're having overgrowth or infection in your gut or other places. My suspicion is that now that fungal overgrowth, fungal infection with secondary oxalate production is her issue, not mold toxin illness.
Yeah.
And I pursued that damn thing for years, and I always, I don't have regret, meaning I don't blame myself, what's the matter with you, because I know that these are complex issues I'm trying to sort out. But I have the type of regret that means, boy, I wish I knew that, 6 months ago, a year ago, 5 years ago, understanding that, I'm not really blaming myself, but it's more of a benign regret kind of a thing.
I'm with you on that. Hey, I found out about oxalates 10 years ago. So if anyone should have regret, it's actually me. But, I'm glad I found it when I did and revisit it. Funny what you say about the mold. I want to just throw this out there. My son, who has really bad allergies, he had asthma for a little while. And in this house, we had some mold issues. And all of a sudden, out of nowhere, he started developing a very, very horrible cough. So I ran the oat on him, and lo and behold, this boy does not eat vegetables. Okay. He just doesn't like him. He doesn't like the texture. He was 7 at the time. He had high oxalates on his test, and it's not from eating vegetables. You know what we found was aspergillus. So aspergillus can actually produce oxalates as part of its microbiome. So I put 2 and 2 together, and I'm like, I am so glad I found this, because he was developing signs of neurological issues with his mood and his temper and all the things you mentioned that you have to deal with. I was starting to see that, and I started to treat him and, revamped his diet, put him on some antifungals and also some binders. And lo and behold, the cough is gone and his behavior has improved. So there is definitely something to be said.
And what potentially would have happened if you didn't figure it out, and you didn't figure it out relatively quickly? I mean, I can't imagine how many meds my son would be on. I can't imagine where he would be. I can't imagine what institution he might be in right now. And so there are so many kids out there with so many issues that can be identified. So in the next life, I want to have a consulting business where I work with the school systems, and I want, and any kid that has any mental health or behavioral issue from the youngest conceivable age, I want to take a full functional integrative approach. There are so many people that have figured out so many root causes for mental health conditions in kids, even a pyrrole disorder. Like if they just did a histamine level and it was low, and which implies a person might be overmethylated, and then they avoid a serotonin agent, it would help so many things. And if they just did a pyrrole test, I don't mean to get off the track now, but
no, it's okay. No, I think it's good for people to hear.
Yeah. So if they just did a urine pyrrole test, which costs just over $100, and they identified a pyrrole disorder that you can potentially correct in a month or 2 with gradually increasing doses of B6 and zinc. I mean,
yeah, B6 and zinc.
Yeah, there are so many issues now that are understood for why children have behavioral and mental health issues, PANS, food sensitivities, gluten sensitivity, dairy. Dairy is probably the #1 cause of headaches in the pediatric population. It goes on and on and on. Actually, a book I'm working on is a functional approach to pediatric mental health disorders. And so, we have to, you and I and other people really have to do our part. And I expect, like you and I talked about this, like whether it's fair or not, a medical doctor is going to be listened to. Now you're a PhD, so that's, you're in the club, right? So they're going to listen to you as a PhD and me as an MD. whereas a naturopath or an herbalist could say the exact same things you and I would say.
Or acupuncturist.
Or an acupuncturist, they would say whatever, good luck with that. So I feel like I really have a responsibility to try to be an intermediary and a go-between as much as I possibly can. I have a friend, a urologist, and somebody asked about interstitial cystitis, and I said, oh yeah, these are usually the elements in play with oxalates. And my friend, the urologist, like, oh, oxalates play a role in interstitial cystitis. Now, this guy is a good guy, brilliant person, super, super smart. It's really not his fault. It's because it's not on the board exam. Doesn't come up at the national meetings. Um, there's a stranglehold on the information that doctors get, and everything that's not part of the standard information is just poo-pooed and dismissed as being, not evidence-based or some nonsense like that. So,
well, that's why it's, that's not what they're supposed to be learning. And that's where it leads me to the next question. The next statement is, maybe a conversation we should have is why it's important for a nutritionist to be involved in the therapeutic plan of these chronic cases. I mean, I truly believe, I'll never know anything about any surgery that a surgeon does. I have utmost respect for surgeons because that's what they do and that's what they're supposed to do. I don't expect my surgeon to understand about how to meal plan my oxalate diet. It's not just something that they should be learning. I mean, they should be focusing on what they're doing. And I same thing here. I'm not going to sit here and learn how, all these different surgical procedures. It's just not my area. So, in a case like this, do you think that if we, in a utopian world, if we had a system where we had a medical doctor on board and we had a nutritionist and we had maybe a psychologist, because I know a lot of those trauma is a whole other area we didn't even get into, but there's definitely I have seen a trend with trauma with a lot of the people I've worked with who also have these oxalate issues. It's almost like, the mental state that they were raised in may have created the gut environment and the dysbiotic environment that may have created the oxalate predisposition. It's really interesting, but I've seen that. So let's talk about that. Then why, from your opinion, why it would be a good idea to work with nutritionists?
Well, it's because oxalates is such a primary role, and it is a complex subject, and in some ways, and you alluded to this before, but it is a bizarre concept for people to tell them that oxalate and beets and rhubarb and sweet potatoes and almond milk and nuts might be harmful to them. I would say to have a nutritionist on board, the first thing is because it gives legitimacy. So if the doctor says it, okay, that carries some weight. If the nutritionist says it and reinforces the same concept, and that's even going to help more. But I would say to you, I don't know what it's like down south, but there are two, or now a third, functional nutritionists around me. I know the three women. I know all of them very well. I've worked with all of them for many years. They don't know oxalates from a hole in the wall.
Yeah.
They don't know about oxalates.
I didn't learn about it in school.
Yeah. So I'll send them. I'll send them. Basically, the short of it is, there's not a single dietitian or nutritionist in my area that I can send to about interstitial cystitis. I guess I would have to say, can you advise the person on, but even they're not going to understand a gradual reduction in oxalate intake. If I say to the person, okay, pretend they have calcium oxalate stones, which is as close as they're going to be familiar with, and can you give them some advice on that? I mean, I've had people on their own precipitously drop their oxalates from high oxalate to low oxalate, in a week because they're motivated. Now, I'm sure you're familiar with this too, but some people, for whatever complex reasons, like do fine, right? They cut from high to low in 2 weeks, and they're like, I feel fine.
Yeah.
Like what I've said to people for 10 plus years is, every piece of information is potentially important, right? Whether I can figure it out or not. if you have a positive response, negative response, no response, a terrible response, you have side effects, what side effects. Every individual factor is potentially useful information to understand what's going on. So there has to be meaning in the person that has a precipitous decline in their oxalate intake and feels fine. And there has to be meaning in the person that has dumping and needs oxalate rescue. Like
And
if
then there's people who are constantly dumping, even though they haven't changed their diet at all. They might be on 50. There's a group of people that are on 50 milligrams a day, and that's all they're taking, and then they're still dumping for years and years and years and years. I mean, that's the other side of the continuum.
Yeah.
Yeah.
And what's their level of fungal overgrowth? What are the, we look at B6 as being crucial, but I'm not saying I understand it that well, but if you look at the Krebs cycle, it's a very complex cycle, and the B6 step at the end where you go to oxalates or not, glycolic acid, I think is the other.
Glycine also has a conversion to oxalates in B1 deficiency.
Right.
So that's why I tell people, don't think if you go on the paleo diet, it's going to solve your problem, because you might be eating a lot of glycine. You know what I mean? So it's the vitamins and the minerals. And that's what I was going to tell you offline. We could talk about this. The hair tissue mineral analysis test, I know a lot of people poo-poo it, but I really dug in and did my research and have a lot of studies that support it. Great test. It's inexpensive, and you can get so much. And you said the children, that'd be great for children, just because you just got to get a piece of hair. There's no pricking, there's no needling, there's no urine collection, no stool. Still hair, and you can get a whole panel.
Yeah, I ran it on my son. He had the highest copper levels I've ever seen, even 10 years later.
Wow.
And it's interesting. I was looking at someone's hair analysis this week, and if oxalates bind pretty much all positively charged minerals, well, that's where the hair analysis is particularly interesting, because you go, like people in that world, Wilson, and people talk about the 4 lows pattern, and people are really on it, but if you look at it from a different perspective and you say, well, wait a minute, really the minerals that are low on the hair analysis are really the most prevalent, predominant, positively charged minerals, like calcium. You see calcium, magnesium, iron, potassium, lithium. You see, my God, you probably see this too, but I would say 3 out of 4 hair analysis I've seen in the last 10 years have almost no undetectable lithium levels.
Yes.
Unbelievable.
Yes.
Deficiency.
And that might explain their heightened sensitivity to pain.
Right.
Because of the neurotransmitters.
Right. This is when you really, when you say that, this is when you really start getting into the nitty-gritty, and really start to understand the individual. Yeah. If you get to that level and say, now I've used lithium orotate as a supplement for many years. It hasn't really set the world on fire for me. I think it's definitely a supporting treatment. Anybody that thinks you're going to cure anything with lithium orotate by itself or replenishing lithium, I've never seen that one time. But anyway, I'm getting off the track again.
Yeah, don't supplement. They say don't supplement a bad diet, but the same goes with the oxalates. Don't try to over supplement. Even I've had people say, oh, you know what? I'll just take a bunch of citrate, magnesium citrate, and I'll just bind it in my gut. No, it doesn't work like that. I honestly think it does take a multifaceted approach, and it's great to have this conversation because, I think some people are going to take away with this and do what you just said and say, oh my gosh, I'm just going to go on a low oxalate diet and that's going to solve my problem. No, not if you still have mold. Sorry. You know what I mean? So there's a lot to be said about this. It's very complicated. You need an expert to help you. And the number one thing that I would give advice, and I want to hear yours, is don't try to do this alone. You need support. This is a condition that I have found majority of my clients who come in, they are lacking support. They need friends and family. It's the first thing I do when I talk to people is, what is your support system? Who do you have at home that can support you? Is it a spouse? Is it a family member, a loved one? Because you're going to need it. So that's what I would my take home with this would be. And you can give one piece of advice to these people listening. What would it be?
The one piece of advice I would give is that it's a marathon, not a sprint, and it's going to take some time. And I know it's frustrating, but there's a pretty good chance if oxalates. So the beauty of oxalates is if that is a prevailing predominant issue for you, we know enough to help you. We understand the elements well enough to address them, but it's going to take time. And it's going to be a rocky path, and it's going to be up and down. You're going to have good days and bad days. It's going to be complicated. It's going to be frustrating. Um, I agree with you about finding somebody to work with, absolutely. But that's hard, right? That's very, very difficult. I mean, in my area, um, there are a few functional people. Um, I'm one of the only ones that takes insurance, but I also have a monthly fee to be in the practice, so I can have a small practice. I have 2,700 less primary care patients than I had 3.5 years ago. So it's just very, very hard to find a versed naturopathic, functional, integrated person that you won't have to spend, $350 a visit. And I'm not faulting anybody for charging, because everybody has to earn a living. It's just very, very hard. And actually, that's where the nutritionists come in. So for right or for wrong, nutritionists don't charge $250 an hour. So you'd be better off having a savvy nutritionist that charges you $80 to $125 an hour, whatever they charge, and you'd be much better off. That would be the ideal perfect person, the person that can work with a physician, but that understands the things well enough to direct you.
So I do know a health coach actually in Canada that I've actually referred people to, because a lot of people can't afford my rates either. And so what I've done is, to be honest with you, my scope is mostly really to dig into the root cause and to dig into the lab. So that's kind of what a clinical nutrition does, as opposed to a dietitian. That's something also I think a lot of people get confused. Is like, are you a dietitian or are you a clinical nutritionist? And they are actually very different. Dietitians will typically, not all of them, but most of them are, their savviness is whipping up a meal plan and putting together, dietary, individualized meal plans, whereas clinical nutritionists were more looking at the biomarkers and trying to get to the root cause. So I did find a health coach in Canada and we can talk offline. She actually is oxalate, the low oxalate coach. You can actually look her up. Her name is Monique Attinger. Awesome person. Actually, may have an interview with her. You can, her name is called the Low Ox Coach, and she actually has a group, which is really awesome. I'm actually part of her group, where she just charges a really low, like $20, $30 a month. That's it, and you can be part of her group where she gives out recipes, and she does a lot of, like, because I think that's where a lot of people are needing support, is the actual recipes. And sometimes they come to me and I'm like, I'm definitely not your chef. I am definitely not your chef. I can tell you how to eat, but I can't tell you what to eat, because that's something you have to figure out on your own. So this is what she does. So she's in the process of putting together a cookbook. She's given out recipes, and she has a group. So if you go on her website, you can look her up and you can find her group, and you can maybe even reach out to her. And I've referred people to her. Some of my clients who just really need that hand holding, and they need somebody to actually sit there and do their Monday, Tuesday, Wednesday, Thursday, Friday meal plan. Those people I've actually referred to her, because I think that's just her area. And when you mentioned how to reduce your oxalates gradually, a lot of people don't want to sit there and whip out the calculator. I mean, I have the calculations. I have all the numbers. I have spreadsheets and everything. And believe me, we can sit there and we can crunch numbers all day long. But most of the people I've dealt with, they don't want to do it. So what Monique has done is she's actually created a system of how to help people, and she'll do like a 6-week program with them to 1 week by week reduce their oxalate intake safely. So
I had two or three people working with her.
Oh, you know her?
Yeah, I know of her. I've never, of course, no interaction. I've had some interaction with Susan Owens, who runs the TLO Facebook group, Trilo Oxalate Facebook group, and I think Monique Ottinger, if that's how you pronounce it.
Ettinger, yeah.
So she and Susan Owens, I think, are fairly. They coordinate together. So
she's an admin of the group too.
Yeah. Okay, that's what I thought.
Yeah.
So
she's awesome.
Articles and some of her stuff in my.
I love her. I bring her on with my clients.
My oxalate pile is like, my oxalate article pile is like, and it's getting bigger and bigger. So.
No, she actually bring her on with my clients, and we do like a small group session. And I've actually brought her on a few times because you know what, she's a valuable resource. And that's the thing, is I truly believe, and that's what I want to say, when we end, You can't do this alone. That's why I reached out to you. You know what I mean? I reach out to people. I do these interviews. Why? Because I don't want to do this alone. I want to be able to partner with people and share knowledge and help each other out. Like, there's no reason to do this alone. This is a beast.
There's too much to sort out. We need
Yeah.
as many people as possible understanding, why do some people get fibromyalgia-like syndromes and some people have it in the bladder and some people have it in their thyroid and Hashimoto's. I mean, how do we explain, some people have it all,
Yeah.
I mean, how do we explain why some people have different systems involved than others? I mean, I saw one yesterday and she's got all left-sided symptoms and some of it's oxalate driven, and she sleeps on her left side and she swims on her left side. So I'm thinking, is it possible that the oxalates settle and precipitate the same way that gout is typically in the toes, because uric acid settles and precipitates and crystals form in the lower joints? Is it conceivable that oxalates would precipitate by gravity while she's sleeping and while she's swimming and cause left-sided symptoms? I mean, that came up with a totally different person yesterday. I mean, I'm not saying that's the case, but I wouldn't want to hang my hat on it. But
that's a great question from Susan.
yeah.
I'm sure she'll have that answer for you. Well, thank you so much for your time. This was awesome. And yeah, we'll touch base offline. I'm sure we have a lot to talk about. And you guys can reach him on, tell us what your website is again.
My website is drlenhardt.com. So it's drlenhardt.com. I have about 80 blogs, a lot of protocols. I've written a couple books. I have references to probably 50 or 60 books that I think are incredibly worthwhile and helped me sort things out. So there's a lot of references on the site. Yeah.
Okay. Well,
Thank you very much. I appreciate it.
Thank you. Okay. Bye-bye.
Thanks.